So I suppose firstly, thanks to the organisers for giving me the opportunity to speak today. As Noreen said, I'm a researcher here. I'm doing my PhD at the moment based between Trinity College and the hospice here. And I'm actually going to be talking about one strand of my PhD which really didn't go very well at all. And actually it's kind of set up like a case study of what Sonia was talking about earlier. In fact, that slide she had of all the challenges, that's pretty much a lot of what I encountered. It was a bit of a saga, especially when you hear it right after kind of the past other two speakers who've talked about their really successful research. But actually, I think there is a value in talking about research that doesn't go so well, because a lot of research gets lost when it doesn't go well. So about 1 in 6 research studies, clinical research studies, never get finished. And even if those that do, only about half ever get published. So there's a huge amount out there that's happened that we actually don't really know. And it might be very valuable to know why research doesn't work for planning for the future. And I think, as was mentioned earlier, there's a real ethical imperative to actually disseminate all research results, because first of all, prevent people doing the same unsuccessful study again. Second of all, to inform future work, but actually to really improve patient care, we need to be exactly seeing what we have done. So today, I'm going to talk about how and why my study struggled, as well as what I did to try and make it work. So my story begins. Once upon a time, I had what I thought was a great idea. So inflammation in cancer is associated with a higher symptom burden and a poor quality of life. It's also associated with change in skeletal muscle, which you can see on CT, and a high CRP, or a blood test measured all the time. So you can see both of those things in purple as markers of inflammation. My idea was that, these objective markers could maybe be used to predict who would develop symptoms and a poor quality of life during cancer treatment. That'd be very useful, because you could use it perhaps to predict who needs more supportive care, or potentially even palliative care referral. But as was already alluded to in Sonia's talk, the challenges of research are well described, particularly retention, and I intended to do a longitudinal study. So feasibility studies are recommended before you start a larger study, to see actually if the study can be done at all. So I decided to do a feasibility study. So exactly the study that I wanted to do, but my primary outcomes would be recruitment rate and proportion of completed data sets. I hope to recruit 30 people with inoperable cancer. So the study process itself, at enrollment, people would have their serum CRP measured. Then I would look at their CT, which they were already having, and record their symptoms and quality of life. Then 6 to 8 weeks later, I would repeat their symptoms and quality of life scores and correlate those with the initial CT and CRP. On the face of it, fairly straightforward. And indeed, I got off to a good start. I was fortunate enough to receive funding from the All-Ireland Institute of Hospice and Palliative Care. I got approval from all the relevant bodies, and I actually found very supportive people in the oncology and radiology departments. So off recruiting I went. So I based the study in the oncology outpatients, recruiting people with inoperable upper GI and lung cancer. And after 8 weeks, I paused to review my progress. So in that time, 18 people had passed through the clinic. However, I had recruited none. So what had happened? Well, 1 was too unwell. 2 were already involved in another clinical trial. But what about the rest? So it actually turned out that I'd shot myself in the foot. So in my protocol, I'd said that I'd review people's CT from the last 1 month. But actually it turned out many people's CT had been 5 or 6 weeks prior. So that was easy to fix. I got an ethics amendment sorted. But owing to other commitments, I also wasn't at the clinic quite as often as I would have liked. And the clinical team had said, listen, you don't need to be at the clinic. We'll let you know when there's a suitable patient. We'll contact you. But the reality is they're far too busy to be worrying about my study. They've other important things to think about. So I suppose bearing all those things in mind, I got ready to start recruiting again. At that point, life intervened. So I found out that I was pregnant. I just talked through it with my supervisor, and we agreed that I should probably defer restarting the study until I could have a clear run at it, rather than stopping and starting. So I went off, had a baby, returned after mat leave, all set to go, all excited. Came back only to find that another study had started in the same clinic, recruiting the same cohort. So clearly it was not going to work for both of us to be there. So back to the drawing board. So around this time, I just happened to go to a talk about networking, and they kept talking about using your strengths and your contacts. So that got me thinking. So I contacted one of the consultants in respiratory medicine who I'd worked with years previously. And he said, look, why don't you focus on lung cancer and recruit from the Rapid Access Lung Cancer Clinic, which he ran. So another ethics amendment, and back I went. So mindful of what I learned the last time, I attended the clinic diligently, week in, week out. And then after 8 weeks, pause to review my progress. So 4 patients agreed to receive information about the study, but then 3 of the 4 declined to participate. They explained they were really overwhelmed with their recent diagnosis. I then managed to get sick the day I was supposed to meet the 4th, and so after 8 weeks, there were still no patients in the study. So I met up with the consultant after the clinic on that 8th week, and he said, "Oh, do you know what? There was a lady today who would have been perfect for your study. I'm so sorry, I couldn't ask her today though, she was just too upset. I tell you what, I'll ring her tomorrow for you." Okay, for starters, a recruitment model that involves the clinical team having to ring every patient the next day is never going to be feasible on a larger scale. But it also raised, I suppose, a more fundamental question for me. Now, this doctor is very experienced and he actually has excellent communication skills and kind of good judgment. And so I wondered if he was finding it difficult to approach people on that day. And furthermore, if 3 of the 4 people who I'd spoken to myself about the study had declined to take part, maybe it wasn't the optimal place to recruit. So we kind of came up with a bit of a nuclear move and decided to move the study to bronchoscopy. Now that's obviously quite a big change because you're talking about people with suspected lung cancer as opposed to confirmed. Now naturally some would turn out to have confirmed cancer. So there were advantages to that. I'd have a nice control group who I'd compare my findings to, but it was obviously going to be a good bit more work as well. So another ethics amendment, and I opened the study in bronchoscopy. So once again, I reviewed my progress after 8 weeks. And at that stage, I'd recruited 28 people, which was one of those moments of pride and joy that we mentioned earlier on. About 1 in 3 had inoperable disease, so I calculated I'd need to recruit 100 people. So I'm happy to say that recruitment actually continued to go really well, and after 8 months, recruitment was complete. 20 people had declined to take part. They mostly didn't give a reason, but when they did, it was usually that they were feeling either too anxious or too unwell on the day. So I'm just going to talk briefly about the feasibility data for the Inoperable cohort, obviously because that's what I'm here to discuss, but I will of course be using all the data and collecting it and hopefully reporting it all. So of the 37, 29 people completed the study. Now that's a 6 to 8 week follow-up. 4 had died, 1 was too unwell, 1 asked to withdraw, and 2 are still pending. Most of the follow-ups were delayed. Often it was because they were still actually undergoing investigations and it wasn't clear which treatment direction they were going in. But also I had a lot of difficulty contacting patients, and a number of people were also unwell and then recovered and were able to talk to me, but they were delayed. So I've obviously thought a lot about this study over the time. I mean, one of the things about this is when I spoke to people at the start, everyone said, look, this is a simple study. And you know, it was a simple study, but it still took 3 goes to get it right-ish. And even at such a short time interval, there was an attrition rate of 15%. Now that's actually lower than what's reported in the literature, but it's still significant. The personal angle also has to be considered. So I did all the collection and recruitment myself, which meant that if I was sick, the study suffered. But there were advantages too. I formed good relationships with the endoscopy team, with the respiratory team, and with the patients themselves, and that actually made a difference. So I rang one person's house to arrange a follow-up, and the person at the end of the phone said, "Oh, he's not here." I said, "Okay, that's fine." I was about to hang up, and all of a sudden the person exclaimed, "Wait a second, I recognise your voice. You're that research doctor. How's the baby?" Now, okay, it tells me that I probably speak too much about myself in the context of research, but that's another day's work. But that person thought I was a crank caller. They thought I was a scam caller trying to sell them something until they recognised my voice. So if it hadn't been for that consistency, I would have lost that follow-up for sure. And I suppose the other aspect of it is the time that it took. You know, everything took longer than I thought it would at the outset. And I know that's the story of research and everyone tells you that, but I can't say it enough. Probably one of the things that was key to getting the study finished was actually having this regular scheduled review. Back in 2011, it was recommended that people use a process of kinesthetic learning for feasibility studies. What they meant by that was that the study actually changes as the study proceeds and as you get experience. So in other words, it's an iterative process where, as you can see in the diagram, where one cycle of the study informs the next. And that's actually recognized in research in the development and evaluation of complex interventions. But is it just moving the goalposts? Well, I don't think so. I think an iterative process in research is actually analogous to the use of reflection in clinical practice. It's the same process of questioning and continuous improvement that we expect of ourselves and our trainees. I'd even go so far as to say there's an ethical imperative to make sure that our patients' time, which is so generously given, is used as well as can be. There's also a psychological advantage to this, because if you see that the study isn't working, rather than feeling that it's failing, you can see that not working as part of the learning and actually use it. So look, in summary, this wasn't the perfect study, but it is done. I suppose I've talked about some of the main barriers which are common and have been addressed before. Probably surprising that in 2019 I'm talking about telecommunications as a barrier, but there you go. The facilitators included good relationships, both with the clinical team, but also with the participants themselves, and consistency. I think in particular, the experience of this study shows the value of a planned interim review and sort of an honest appraisal of what's not working. And I think that's probably an important part of what we do in palliative care research when it doesn't work, which we know it often doesn't. So I'd just like to thank the following for all their help in the planning and conduct of the study. And I'll leave you with this thought. So thank you for listening.